testing, that is the so-called PCR testing. Over 300,000 of those tests will continue to be distributed. So we are not abandoning our major test, which is a molecular test. We are just supplementing that with other tests. In terms of other capacity, we now have trained through the Institute of Workforce Development over 11,000 clinicians and equipping them with the ability to the latest information on case management of patients across the continent. We have also, in the last week, begin training of healthcare workers on vaccination, and that will be in partnership with the Project Hope from the US and Brown University, where just last week we trained over 150 clinicians and AP managers in Ethiopia and South Africa. And such training will continue in the coming weeks, especially with the Francophone speaking African countries. Let me just conclude by expanding on the vaccine activities. As you've all heard last week, this week was like, I'll call it a tipping point in what we have been expecting, where many countries started receiving vaccines from the COVAX facility, and we are extremely appreciative of that. These include Nigeria, DRC, the Republic of Kenya, Cote d'Ivoire, Angola, Republic of Rwanda took delivery of their first COVAX vaccines, and this list is perhaps not exhaustive because, as we speak, there is an accelerated move to begin to distribute the first doses of the vaccines. What we plan to do next week is to have an extensive catalog of what exactly the number of doses that each country is receiving, so that we can discuss that more openly. But for this week, we have some numbers, but it's still premature to be putting out numbers there. As the vaccines are distributed, as we have discussed on this forum again, we have a simple formula that says vaccine plus vaccination equals life saved. So yes, we are having vaccines. We now have to focus on the vaccine delivery. And as such, Africa CDC, as you know, has launched what we call the African Vaccine Delivery Alliance, in abbreviation AVDA. And this is really similar to the consortium that Professor Karim is chairing. Is co-chaired by our colleague, Dr. Yodi, based in Nigeria, and myself. And the whole purpose is really what we call a coalition of the willing, to come together, bring all our assets together so that we can deliver vaccines and support countries across the entire continent in the areas of setting up vaccine centers, in the areas of cold chain delivery, in the areas of training at scale, and in the areas of logistics, overall logistics of supply chain management. So that is what that alliance is meant to do. And you heard last week when we announced that the European Union had committed 100 million euro to supporting us, and we are in the process of finalizing our work plan on how to use the 100 million euro to support this alliance so that we can make sure that the vaccines, once they come in, they are rolled out, you get the finality is getting that needle into somebody's arm, and then we can tick the box, and we know that that person is protected, and not just protecting him or herself, but protecting their loved ones. Another, along the spirit of good news, you also heard last week that the United States Food and Drug Administration issued an emergency authorization use for the Johnson & Johnson vaccine, which is a single-dose vaccine. And the African Regulatory Task Force, which we are co-leading, will be reviewing the vaccine for its use on the continent as well. And we had earlier issued guidance on how these vaccines will be introduced on the continent. We will be hosting a 2-day conference, high-level conference, chaired by His Excellency Musa Faki Mohammed, the chairperson of the African Union Commission, President Cyril Ramaphosa in his capacity as champion for COVID, and His Excellency Felix Tshisekedi, who is the current chair of the African Union, on April 12, where we bring all stakeholders together to discuss a framework on vaccine manufacturing on the continent. We'll be looking at 3 things. One is, how do we support manufacturing on the continent so that by the end of the year or in 1 year's time, manufacturers begin to produce COVID vaccines. And that will be a comprehensive meeting with all stakeholders, not just within the continent, but outside of the continent, including donors as well. Secondly, will be to use the COVID pandemic and crisis to strengthen our overall manufacturing across the continent so that we do not get ourselves into this scenario where we scramble for vaccines on the continent. And thirdly, how do we establish centers or hubs of excellence across the continent so that it can get involved in research and development for vaccines? So, colleagues, let me at this point conclude this, and I will let we will go forward and do Professor Slim Karim so that we finish the COVID section, and then we'll do the Ebola briefing last, so that there is some aligned with the COVID story. So over to you, Wayne.
Very right there. It does make sense for us to finish one topic before we move on to the next. So now we invite Professor Salim Abdul Karim. I have already introduced him, and Dr. John has also said something about the great work that he's doing. So without much further ado, let me invite Professor Abdul Karim to address us. Prof, you have the floor.
Thank you very much, Wynne, and thank you very much, John. It's a great pleasure and an honor to be with you here this morning. I will be sharing my slides. I'm just checking if you can see my slide.
Yes, we can.
Okay,
Prof. Yes.
Wonderful. So let me just start by acknowledging the good work of the African CDC, and I don't say so because of my good friend John Kengasong, but because I've been at the coalface and I've been able to personally witness the hard work and dedication that has really enabled us across the continent to respond appropriately to this pandemic. So what I want to do in the next 10 to 12 minutes is I'm going to tell you quickly about epidemic trends and about variants. And let me start off with, what's the situation in the world? Well, we all got a surprise that in the middle of January, on the 11th of January, the epidemic started declining at a global level. And we saw for the first time ever in this entire epidemic, almost a year to the day, that the epidemic showed a consistent decline from the 11th of January to the 18th of February. And over those 5 weeks, the epidemic at a global level declined by just over half. So that's quite a steep decline and a consistent decline. Unfortunately, it's sort of not staying that way. It's now trying to decide whether it wants to stay flat or go up. And we'll keep a very beady eye on that. And I'll talk about this decline because it's really a very significant decline, because we've seen declines before, but those have been declines for a week. But a 5-week decline in this way, well, the first is to recognize that the pandemic is a mosaic of country epidemics. And you can see that in the way in which the countries are colored differently in the slide on the right-hand side. And you can see that our continent has been much less affected compared to North, South America, or Europe or Asia. But you can see that at the far end of Southeast Asia, that those colors match much of what we see in Africa. So we have seen a global decline over 5 weeks. Well, when you look at that decline, you want to understand what are the drivers of that decline. Well, the drivers of that decline are principally the declines we have seen in the US and in Europe. And the reason why we're seeing those declines, I'll come to in a minute, but essentially countries in North America and in Europe are now completing their winter second waves. If you look at, so how are we in Africa contributing to the global pandemic? Well, I have to say, thankfully, a very small contribution. if you look very carefully, you'll see Africa right at the bottom, above March 1st, 2021. So we make a very small contribution to the global pandemic, and we have a minimal impact on the global pandemic numbers and the global pandemic trajectory. And let's look at, so why are we seeing this decline? Well, if we look at Africa, we've contributed in a little way to that decline because we've seen our own decline, and that decline that we are seeing is being influenced by South Africa largely. And you've already heard the numbers, so I won't go through it. Professor Nkengasong has outlined very clearly where we are in the global pandemic. So let's go on to the 4 key reasons why COVID-19 cases decline, so that we understand what we are observing in the global trajectory. So the first is that if you take the population, there's a subgroup, a small subgroup of people who are those are individuals in high-risk occupations. So those individuals who are most at risk, they tend to get infected quickly when the epidemic is increasing. And once they've been infected, they are now immune. Now, we haven't reached herd immunity. Herd immunity requires a much higher level, but we are saturating with the natural immunity those who are most at risk. And so they don't get infected again, so we start seeing the numbers decline. The second is, of course, the impact of government interventions. That when you reduce the movement of people and gatherings, you decrease viral transmission. That's very clearly seen in South Africa. That when you look at when the government imposed restrictions in December, exact restrictions in December, exactly 10 days later, our epidemic starts to decline, as you would expect in relation to the incubation period. And so you see the impact after the incubation period. Then we see an increase in protective behaviors during the waves. That when we have the cases going up, people become aware. And the whole issue of cases, people who are sick, people who are dying, becomes personal. The issues become personal. Somebody in your family, somebody you work with, somebody you know well. And so what happens is that we see an increase in protective behaviors. So it's a combination of people getting the most at risk, becoming infected and immune. It's government interventions. It's about protective behaviors and people taking protection personally. And then finally, it's the cyclic nature of the waves. And we see that very clearly in South Africa. If you look at our first wave, which is sort of more like an African Mount Kilimanjaro number of cases, and you can see the hospital admissions in the gray bars. If you compare that to our second wave, which was driven by the 501YB2 variant, you can see how the cases rose much faster and to a much higher level, akin more to like a Mount Everest than a Mount Kilimanjaro. And you can see that it wasn't just that the cases rose. The number of hospitalizations rose dramatically. It put a huge amount of pressure on the healthcare system in South Africa. And as a result, deaths go up. So we have now recovered from the second wave. The cases have declined for the reasons I've just outlined. And we are now in a situation of low transmission. And the government has eased restrictions and we are back to level 1, which is the lowest level of the restrictions that we have in place. So that's where we are in South Africa. I'm going to talk very briefly now about variants, because this picture that you see in our second wave is a picture of the impact of the 501YB2 variant. So what do we know? Well, globally, there are 3 variants of concern. The first is called the B117, and that was first described in the UK. It has lots of mutations, 23, but importantly has this one key mutation in the receptor binding domain, in that part of the virus that attaches to the human cell. Then you have the 501YB2 variant we described from South Africa in December. And there, the difference is that this variant has 3 mutations in that key part of the virus that attaches to the human cell. And then more recently, we've seen from Manaus in Brazil, the description of the P1 variant, which has more mutations and also has the same 3 key mutations in the receptor binding domain. So globally, we have these 3 variants of concern. The one I'm going to talk about is the one in the middle, the one that we know is present in South Africa and indeed is now occurring in other countries as well. So what do we know? Is it more transmissible? Is the virus spreading faster? Well, let's just look at one province in South Africa. If we look at the Western Cape and you look at its first wave in the light green line, you can get some idea of what the wave looked like. Compare that to the second wave, driven largely by the variant. You can see that the cases rose much faster, higher, and then from the peak declined quite rapidly as well. So if you compare the two, it took the Western Cape 50% faster to reach 100,000 cases in the second wave, 54 days, compared to the first wave, 107 days. Now, there are many caveats to just drawing a simple comparison, but it gives you some idea of what the difference is. Our colleagues from the London School of Tropical Medicine and Hygiene have done a modeling analysis, and they find similarly that the variant is 50% faster in the way in which it's transmitted. So the variant spreads faster. So what do we know about whether it escapes immunity? So this is a bit of a challenge because we want to know, can you get reinfected? If you were infected in South Africa's first wave with the previous variants of the virus, are you protected against this new variant? Well, just serendipitously, a vaccine trial that was being done in South Africa had 31% of its participants had past infection. And they measured the attack rate. And what they show is an attack rate of 3.9%. And it was the same whether you had past infection or you didn't have past infection. This is the first empiric evidence we have to show that past infection provides only minimal protection against this variant. And it's been confirmed by a range of laboratory studies. Penny Moore's group, based at the NICD in Johannesburg, and Alex Segal's group, based here, they're just one floor above me, their labs have shown that when you look at convalescent serum from South Africans who were infected in the first wave, you get, I'm just waiting for James to mute himself, you get high levels of immune escape with the 501YV2 variant. So it looks like that protection from the first wave is not provided against this new variant. But as you might have heard yesterday, our scientists have found that if you do get infected with this variant, that it stimulates very good immunity against itself. And so you would be well protected against getting this virus. And because of its cross-immunity with many of the other variants, it also does well in preventing the previous variants. So what do we know about vaccines? How do these variants impact vaccines? Well, if we look at the B117 variant, there's minimal impact. You see slight declines in neutralization, and there are different assays that are used. I won't bore you with those details. But if we look at the 501YV2 variant, and I've here listed the 8 vaccines for which we have clinical data of efficacy, but not all of them we've got evidence yet of how their immune neutralization is impacted. But we can see that for the 501YV2, we have differing levels at which the vaccine immunity that's in the blood of vaccinees, we look at how well can they kill this 501YV2 variant. And what we find is that the activity of their antibodies is lower. Now, what does that mean? It's not very clear. It's still under deliberation as to what these mean. But let's look at clinical efficacy. Does the variant impact how effective it is? And we only at this point have evidence from 3 vaccines. And on 2 of them, we only have evidence for mild disease. we only have evidence on mild and severe disease for one vaccine, and that's the Johnson & Johnson vaccine. Well, if we look for mild disease, we see for AstraZeneca that the vaccine is 70% efficacious in the UK and Brazil, but only 22% effective in South Africa in the midst of the 501YV2 variant. Similarly, the Novavax vaccine was 89% effective in the UK, but 49% effective against the 501YV2 in South Africa. Johnson & Johnson showed a much smaller decline, from 72% in the US to 57% in South Africa. We don't yet have clinical data for the other vaccines, and it's unlikely we're going to be getting clinical data because it's not practical. These studies take so long to do.